go ahead and take it away.
All right, thanks, John. Hi, everyone. I'm Amelia, second year resident here in the program. And today I'm going to talk about trauma-informed lens to care of our patients. So I have no conflicts of interest, and here are the learning objectives I have for us today. So I'm hoping that over the next 40 minutes or so, we will together kind of go over how to best understand how systems of oppression relate to trauma, and then describe how trauma and toxic stress impact health, and evaluate strategies to incorporate a trauma-informed lens into the care of our patients. So this is my positionality statement. It's something we've talked a lot about in the health equity pathway, kind of where do we come from as individuals with regards to a topic. So some of that, this is a very dense paragraph, but just to highlight a few things, I'm in the primary care track and my continuity clinic is within the Madison Clinic at Harborview. I identify as Filipina and white, and I have a hearing loss. I've had a lot of significant privileges in my life due to my identities as a cisgender, heterosexual, and a white appearing woman with a graduate education and middle class upbringing. And with regards to today's topics, I think that my knowledge is still growing, and a lot of what I've learned so far is based in the professional work I've had so far, both here in Washington and also in Colorado. With that being said, I'm not an expert in this topic by any means. It's not meant to be all encompassing. I'm still learning. And with honestly, there's a lot that could be covered with regards to trauma informed care. Um, any omission is not intentional. And at the end or even throughout, I would love to know if there's anything else that you all would consider. Um, I think some of you may even have more expertise than I do, and I would love to hear from you throughout. So I welcome you to jump in. And then the other piece is this is a challenging topic. I will be talking about trauma, and for each of us, we need to take care of ourselves. And I welcome you to take the space that you need at any point throughout this lecture or this talk. Um, with that being said, here's the roadmap for today's talk. The first part will focus on trauma and a couple of specific pieces of trauma, including ACEs, intergenerational trauma, systems of oppression, everyday discrimination, and then how does that translate into, how does that look on a physiologic level? And then the second part will kind of focus on trauma. What does a trauma-informed lens look like when we take care of our patients? So I'm hoping this will work. I would love to do a word cloud actually. So if you could take your cameras and scan this QR code, or um, you can type that link into your internet search bar, and then I will put it into the chat here too. I'm gonna give everybody like 10 more seconds to pull that up.
I'm not sure if others are experiencing. I have a message that says pre-registration required.
Oh no.
I don't know if others were able to.
All right, we might not be able to. I might just have people put things into the chat then. I was hoping to be able to create a word cloud, but okay, a pre-registration message. Sorry about that. So maybe we can just pivot and oh, Jonathan is saying to log in with email and it works.
Well, why don't we see if it works?
Okay. Well, why don't you try your UW email? And if somebody could let me know if that worked. If not, we can do something else. Okay. Um, well, what I was hoping to I was hoping to hear a little bit from you all just on this question. So When you think about the word trauma in the context of healthcare, what comes to mind? So if you're able to do the word cloud, um, I think if you could put your thoughts in there, or if you're willing to, you can put your thoughts into the chat. All right, thank you all. Yeah, sorry, I don't think the word cloud is working. I was really excited, but that's okay. Thank you all for trying. So yeah, thanks for those of you who have put some thoughts into the chat. Sounds like we have sexual assault, trauma informed care, um, trauma and the experience of trauma is tied to power and having power and autonomy taken away from you, repeated injury, and is very common. Yeah, thank you all. I definitely agree with those thoughts. Um, and so, kind of to go into this a little bit further, when we think about trauma, the I think the CDC would define it as a physical, cognitive, or emotional response that's caused by a traumatic event or set of circumstances. And ultimately, those circumstances or events are harmful or life threatening to that individual. Um, and there are many different types of trauma, as we can see here in this diagram. This came from some researchers. Lewis O'Connor has done a lot of work with this particular diagram. And we can kind of see that there are a lot of ways in which people experience trauma in their everyday lives and over the course of their lifetime. Um, there, we can see kind of the smaller circle here in the very center. There's trauma at the individual level. And, this is kind of related to Eamon's talk from earlier. We also have trauma on the interpersonal and collective levels as well. Our discussion today is going to be limited to just a few of these events or circumstances given our time. And I think kind of thinking about how trauma appears for everyone is an ongoing learning process for me as well. But we're going to focus on just a few of these. So, um, as we saw in the previous slide, the adverse childhood experiences are just one form of trauma. And I think this is probably a topic many of us have heard about or learned about to varying degrees. So I'm not going to belabor this too much, but I think it is an important concept just to touch on briefly. So the ACE study, as some of you might know, it was conducted between 1995 and 1997 with Kaiser Permanente in San Diego in collaboration with the CDC. And basically, they were trying to look at the association between these adverse childhood experiences that we see listed here on the slide and kind of long term physical, behavioral, and mental health outcomes. Um, so these are the types on here on this slide here. We have kind of the different types of adverse childhood experiences that they have identified from that study. And from that study, we've learned that almost 2/3 of adults have had at least one adverse childhood event experience in their life. And then the study also suggests that there's a dose response relationship between the number of ACEs experienced by an individual and long term negative health outcomes. So someone who has four or more ACEs has an association with significantly increased odds of developing any of the 6 of 10 leading causes of death in the United States. And so we have this establishment of associations between ACEs and kind of the risks for um, negative, I guess, sort of long term or chronic physical, behavioral, and mental health outcomes. But in my kind of preparation for this talk, I also learned that there's been some literature around positive or benevolent childhood experiences. Um, And this is still very much emerging. I think it's still something that's is worth further exploration. But some of the examples that I came across of positive childhood experiences include kind of secure attachment style, positive relationships with community members, friends, neighborhood safety, and then equitable access to needed resources. I will say I didn't find super strong evidence for positive childhood experiences as we do with ACEs. The studies I found were mostly cross sectional. And so it's hard to establish a causal relationship there. But one cross sectional study this was suggestive of a dose response association between positive childhood experiences and then of lower odds of depression or poor mental health later in life. Um, and then another cross sectional study suggested that the presence of positive or benevolent childhood experiences could actually counteract the negative effects of ACEs. Um, so I think that was something just to maybe keep an eye out for in the future. Something to think about with our patients as well. Oh, sorry. Okay. The I'm gonna move into kind of the next um topic or the next concept here, which is intergenerational trauma. So um this also kind of I think ties in well with what Eamon was talking about earlier. So this concept of intergenerational trauma is it can be complex, but at its simplest level, it just acknowledges that exposure to extremely adverse events can impact individuals um, to such a great extent that their offspring are also then grappling with those adverse events. Um, and how does this kind of occur? So there can be so if there is a parent who experiences an adverse event, there's some thought that perhaps there's early life exposure or in utero exposure, postnatal care that can then impact the child or the offspring's long term health. And then there's also been a lot of research into whether or not that adverse event in the parent can actually cause epigenetic changes in the child, and therefore the child also experiences these long-term health consequences. Um, so I think just a quick example here, if somebody has an early life exposure through to traumatic events, whether in utero or postnatally, that can affect their neurobiology, cognition, and then there's an increased risk for PTSD across their lifespan. There's been quite a bit of research into this. In my review of the literature, in particular, there was one researcher who has looked into how the Holocaust specifically has impacted subsequent generations of Holocaust survivors. And these researchers did find that there are changes in the activity of the DNA segment that regulates stress response. And they found those changes not only in the Holocaust survivors themselves, but also in their children who were not directly exposed to the events of the Holocaust. And then another group that's where we might see this, and to be clear, this can happen in many different groups, but another, some literature that I came across was how intergenerational trauma has showed up in indigenous communities. And one prominent example was the stolen generations. So the Aboriginal peoples in Australia were displaced and taken from their home and experienced significant trauma. And that has had negative consequences on not only those individuals, but their children. Um, yeah, thanks, Liam. So famous mouse experiment where the pregnant moms were exposed to trauma and the offspring were also found to experience anxiety and stress for 3 generations. I didn't realize it could go that far. Thank you. Um, and intergenerational trauma, I think, can sometimes be distinguished from historical trauma. So they are very closely tied together, but sometimes those two concepts can be distinct as well. So, kind of moving forward, the next component of trauma that I was hoping to delve more into with you all is just how systems of oppression tie into trauma, into the daily lives of people and throughout generations as well. So, I really like this graphic from a doctor who's also an artist and activist named Rupa Maria at UCSF. And so this diagram kind of shows how, at the very top, the kind of isms of our society, including colonialism, white supremacy culture, capitalism, all contribute at the end of the line to this trauma and underlying inflammation and physiologic changes in the individual. So just to kind of follow one of these arrows, so colonialism leads to supremacism and white supremacy, which then leads to slavery, genocide, which are experiences of trauma that then lead to inflammation. So I think this was a really powerful diagram for me in particular, and I wanted to share it with you all. Um, And so this will kind of introduce our next couple of slides, which will go into how does trauma or toxic stress look at a physiologic level. And the idea is that over time, the chronic stress of experiencing trauma or discrimination kind of wears away at the body at a very physiologic and molecular level. And this is a hypothesis that's actually been proposed by a couple of different researchers. Dr. Arlene Geronimus was one person who suggested this weathering hypothesis. So we're going to take a look a little bit closer at this physiologic level. So we before on the previous slide, we were looking at big systems of oppression and how it trickles down into trauma at the individual level. And some of those are very traumatic events. They're major life events. But I think it's also important to acknowledge that everyday discrimination is also a form of trauma. And it also impacts folks in terms of their long term health. So, everyday discrimination has been looked at further by Dr. David Williams, who actually created this everyday discrimination scale way back in 1997. And the scale sort of asks different questions about what types of discrimination folks have experienced. Um, and this everyday discrimination has actually been studied by many different researchers, and it's been coined as a complex trauma. So it's chronic and severe, and certainly has long term health outcomes. There's here on this slide are just a couple of the things we've seen so far that are related to everyday discrimination. So, um, adolescents have been found to have cortisol abnormalities due to everyday discrimination. There's a greater incidence of metabolic syndrome, increase in blood pressure, and racial disparities in maternal and infant health. This only scratches the surface, really. There's much more that could be tied to everyday discrimination. I apologize in advance. I think this slide is a little hard to see, but I just wanted to step into our kind of uh, pathway, molecular pathway, physiologic pathway side of the brain for a second and really consider how toxic stress and trauma shows up at a biological level. So, these researchers here on the side created this really wonderful chart here that tells us all the different systems that are impacted by toxic stress. And I'm just going to read a couple of them to you since I know this slide is hard to see. So we have our systems over here on the left. The first one is the neurologic level. So we've seen that there is a dysregulation of the hypothalamic pituitary adrenal axis as well as the sympatho adrenal medullary axes. And that dysregulates our hormones like cortisol and adrenaline. And that makes it really hard to modulate the stress response. Another neurologic impact is actually a change in the size of the amygdala. And that change in the size of the amygdala can increase the fear response. I won't read too much of those other ones, but on the immunologic level, there can be an increase in inflammatory mediators, particularly the Th2 response. And so that can actually lead to an increased risk of infection and autoimmune disorders. The endocrine and metabolic impacts were interesting to me because it looks like there's been some research into how toxic stress can actually change the leptin, ghrelin, and lipid metabolism. And then that can lead down the road to metabolic syndrome or insulin resistance. And then we've kind of touched on the epigenetic and genetic changes. And the last thing that I'll just touch on is there's been some research into how the telomeres are actually eroded away in folks who experience toxic stress. And that can actually increase risk for cancer and early mortality down the road. Um, the next slide here is just kind of a reminder of kind of toxic stress and allostatic load. So um, I had to remind myself of the different kinds of stress responses. And in my review, there's three main types of stress responses that we want to remember. So there's the positive stress response, which is very normal, like your first day of school. That's expected, and your stress level goes up and comes back down to kind of this homeostasis or set point. The second type of stress response is tolerable. So you have a response to a more severe stressor, but it's more limited in duration. So maybe like a broken bone or something like that. Your stress response is going to be more intense than your stress response to a first day of school, but you will still ultimately maybe come back to your set point. And then toxic stress is the experience of being exposed to a strong, frequent, prolonged adversity, something like emotional abuse, keeps the stress levels quite elevated. And so then the set point becomes altered. And so the set point is actually much higher than it was before. And that's kind of what we refer to as the allostatic load. Um, I just included this slide so we can take a little bit of a closer look into just one example of, kind of like the table we were looking at earlier, but one example of how toxic stress results in a long-term health outcome. So here we have how kind of a schematic of how toxic stress can lead to atherosclerotic disease and ultimately cardiovascular events. So just to remind ourselves of this pathway, the brain experiences a stressor, goes to the hypothalamus, which then activates the pituitary gland, and then ACTH goes to activate the adrenal glands and the sympathetic nervous system. Um, the RAS is activated, neuropeptides are released, adrenaline is released, and then our glucocorticoids are released. All of that, if it's sustained over a long period of time, results in inflammation, endothelial dysfunction, increased heart rate, increased blood pressure, and oxidative stress, which ultimately leads to this buildup of an atherosclerotic plaque and the risk for rupture down the road. Before I move on, then the next piece of the talk is just about we're switching gears a little bit to trauma-informed lens and how we take care of our patients. But any thoughts before I move on? Okay. I think I'm going to skip this because it wasn't successful the first time. I did have another poll, but we're going to kind of think about what does trauma-informed care mean to you. I think for the sake of time, we'll keep moving forward. It is something that I'll ask you to keep in the back of your mind as we move through the next couple of slides. Um, so a trauma-informed approach, I think maybe many of us have been exposed to these concepts. I think in my review of what has been done elsewhere, there's actually one organization that has come up with a set of principles for a trauma informed approach. That would be SAMHSA, or the Substance Abuse and Mental Health Services. They've created these 6 principles here that they believe should be part of a trauma informed approach. So, the first one at the top here is safety, both physical and psychological. The second piece is trustworthiness and transparency. It was interesting to me that they really highlighted that organizations should be transparent, as should the providers. Peer support was another principle. So, peer support with others who may have the same lived experience. Um, Collaboration and mutuality was the fourth principle here. So, how do we level out power differentials between staff and patients and amongst organizational staff? Um, to really get at shared decision making. Then we have empowerment, voice, and change. So, asking permission, supporting the patient in their choices rather than telling them what to do. And then finally, kind of this, as we've maybe talked about a little bit so far, acknowledging the cultural, historical, and gender issues at play. And so things like offering culturally responsive services, and addressing historical trauma is an important piece. So with that in mind, I had kind of one application for us to consider. I'd love to know your thoughts. So this is a case where you are in your continuity clinic and you're about to meet your next patient for the very first time. This patient goes by G. There are no outside records available, and all you know is that G is here for burning with urination. The intent here is not to diagnose anything. I'm not trying to create a differential diagnosis or anything. I'm specifically interested in what you're thinking about in your approach for caring for this patient. And as kind of an extra credit, if you were in the ED or on the wards, what would you change, if anything, about your approach? So I'd love to hear your thoughts in the chat, or you can unmute. Um,
I guess one thing that I would comment on is the fact that there are no records in our system or really care everywhere records or anything that we can access may indicate that this person has had fairly infrequent encounters with the healthcare system, and that may be driven by some past trauma with the healthcare system. So just kind of a general thought, although there's lots of other considerations as well.
Yeah, thanks, Connor. I think I've had a couple patients like this, and I sort of think about the same thing of where are they coming from in terms of their prior healthcare experiences, and kind of what has happened so far. And so, kind of moving into what a trauma informed lens might look like. Um, these are just a few of the things that I think about. And again, this is not all encompassing. There are many additional components of a trauma informed lens that could be added, but these are kind of my thoughts. Um, so I think the first two thoughts that another couple of things that come to my mind is just the importance of language, and the physical exam. So with language, there was a lot of emphasis in the literature on kind of reframing our curiosity. So not kind of what's wrong or what has happened, but how has what happened impacted you, your family, um, or your parents. And this doesn't need to be explicitly stated necessarily to the patient. It's not their job to tell us their trauma. And I think in healthcare, it can be a very re traumatizing experience. So just trying to, I say this because I try to keep it in the back of my mind as my approach going into the room rather than a question I ask. Something I think a lot about is the language we use both in our discussions about patients and in our documentation is trying to avoid stigmatizing language as much as possible. So things like non-compliant or difficult or addict. Um, it's it's not really person first language, and I don't think that those terms or similar terms really reflect what might be going on with this person. It's not acknowledging kind of the story. Um, and then, yeah, I think I just go into a lot about being mindful in the terms we use. And then finally, being really intentional and using the terms that patients prefer. So their preferred name, their pronouns, the way that they refer to their body parts. I think those are really important things to establish. And then for the physical exam, I have to give a lot of credit to Magna Shaw, Ainsley Duncan for their talk about a lot of these concepts and particularly about physical exam during our health equity block. But some things that I like to try to think about during the physical exam. So before the exam, I recognize that there are a lot of components or elements of the exam that can be really uncomfortable for folks. And so laying out exactly what parts of the physical exam would be helpful for this particular case, and then asking how comfort can be optimized as much as possible. And then during the exam, a couple of helpful tips that I kind of took away for myself is that um, while we're talking throughout the physical exam using clinical language and saying the instead of your, it tends to be more of a professional approach. Being very mindful of how we gown and drape during the exam. And then asking permission with each step is never wrong. And that way the person doesn't feel like they have to go through every single component. They have the option to opt out at any point. Um, and then remaining within eyesight of the patient, always in front, not ever behind the patient is something that I try to be mindful of. And then just keeping in mind the physical exam elements that can be really uncomfortable for those who have experienced trauma, including the oral, thyroid, and TU exams. So for the thyroid exam, for example, I was taught in medical school to kind of do the two-hand method. And I find that to be a little uncomfortable for myself and patients. So I really try to just do one hand and I'm in front of the patient. And I think that's maybe not what I was taught, but I think that is more patient centered in my experience so far. And for other sensitive exams like the speculum exam, sometimes it can be helpful to have patients sit as upright as possible rather than lying all the way flat, and offering a mirror if they would like. And then some patients may actually prefer to place the speculum themselves. So it's just some things to kind of keep in mind that I've thought about.
Amelia, there's a couple of comments in the chat. If
Oh yeah,
you may have covered them, but I just wanted to uh, have you react to them.
sure. So Shelly, I think, yeah, Shelly says, oh, thinking about our case, excuse me, trying to understand why this patient's coming now. Do they have a specific goal besides diagnosis? Yeah, exactly. Kind of what else could be going on here? And then Lily says, trying to preface questions as much as possible, explaining why I'm asking certain things and give them the option not to answer. And then also asking ourselves, what's the purpose of certain questions? I love that. Yeah, kind of do, is it appropriate to be asking the questions that we're asking? And maybe requires a little bit more thought and intention, but I totally agree. And then Amen says, yes, requires a lot of intention and forethought to do it consistently. I agree. I think it takes practice. It's not something maybe that happens overnight, but something that I think we're all trying to practice for. My last couple of slides here are just about a couple of other components of trauma-informed care. So this is getting a little bit more into the environment and safety. So I think this was mentioned in the chat earlier that healthcare settings can be very traumatizing for folks. It may not feel safe or comfortable to many or even most people. And so disclosure of trauma is not the goal. Retelling trauma can be very traumatizing. And when, I really appreciate Amen for talking about kind of screening earlier, because there are times when it might be important to think about. And when we do think about it, like Lily said, being intentional and kind of the questions we ask, why we're asking them, and trying to be maybe open-ended as much as possible. These are some other proposed strategies to mitigate re-traumatization in healthcare would be harm reduction, shared decision making, individualized care, and then also welcoming the individual to give feedback at any point throughout the visit. This was proposed by a couple of different places that are trying to implement a protocol for trauma-informed care at their respective institutions. And then not only recognizing trauma, but also resiliency and strength, I think, is also important for us to keep in mind. On a more institutional level, and kind of what else is out there that's part of our trauma-informed care. So I kind of alluded to this, but there are some institutions that are trying to create policies for trauma-informed approaches to care. This can make trauma-informed care more standardized across an institution. And there are actually a lot of different tools from what I saw that institutions can use in order to implement a trauma-informed approach to care. I think this is worth considering at an institutional level, because things like screenings or documentation, it might be good for an institution to have a policy so that the person, the patient, is not having to retell things over and over again. So I think this one consideration with regards to maybe a policy for institutions. And then, there's a lot of changes we need to make kind of to address the root causes of trauma. So what policies can we put in place and advocate for as physicians to dismantle these systems of oppression? That is a whole other talk in and of itself, but I just wanted to bring it up as another way to mitigate trauma-informed care. Or to mitigate trauma, rather. And then what was interesting is that some of the biomarkers we talked about on the slide, and the really busy slide with the chart, there's been some research into how precision medicine can be used to address kind of those specific biomarkers like leptin or ghrelin. I don't have anything more specific than that, only that research is happening, and that was kind of interesting. And then there is this center that's doing a lot of work into mindfulness-based cognitive therapy and cognitive feedback, and using those two interventions as strategies to treat trauma kind of over the long term. With that, that was kind of a whirlwind, but I just wanted to say thank you to Ryan and all my amazing health equity co-residents and all the other amazing residents here today. Thanks for engaging with me. And then I just wanted to give a shout out to Dr. Shaw and Dr. Duncan for their expertise and the inspiration for this talk during our Health Equity Month. Here are my sources, and then thank you all, and would love to hear if you have any other thoughts or questions.
Acknowledging Eamon had some thoughtful comments in the chat. There's a question here. Any data to suggest that with appropriate interventions, allostatic load can be reduced or back to baseline?
Yeah, that's a great question. I didn't come across any of that data. I was sort of wondering the same thing. I unfortunately did not find anything that suggests that, but it could be out there and I just missed it. I don't know. It's the short answer.
I'll acknowledge that I know that I feel oftentimes overwhelmed thinking about all of this in that it oftentimes feels bigger than what I'm able to do in the space of a clinic visit. But I do appreciate sort of your comments about how to approach every visit in terms of a trauma-informed lens, trauma-informed care lens. Can I ask you, Amelia, if I might ask the first question? In the era of open notes, how do you think about documentation and avoiding re-traumatizing patients in terms of how you document and how you write your notes?
Yeah, I've been thinking about that recently, and I be interested to hear what others do as well. But I suppose that I try to limit, what we talk about in the visit. I try to limit my note to what we talk about in the visit without kind of any extraneous information, if that makes sense. And if something is particularly traumatic, I might let the patient know, like, hey, I'm gonna just put this in your note once and it's gonna be there and you might see it. Would that be okay? Kind of asking permission if it's okay to do that. And of course they could say no. And I might put it in my sticky note at the kind of top of my patient screen. Um, I don't know if that's the right approach, but I like to just ask people if that's okay and if it's gonna or ask kind of what are your thoughts on having this in your chart and potentially seeing it later and having a discussion around that.
Yeah, I think that's very important. I know that I've had patients come back to me and ask me to take out things, for instance, or that things that we have talked about, they've said, um, I'm uncomfortable with you saying those in my note. Doesn't happen often, but again, I know that people are seeing notes. I think your comments about, there are oftentimes things, and I think we're more mindful of them than we have been in the past, where we used to routinely say things like morbidly obese patient, right? I mean, there are things that we, I think, should be very thoughtful about why we're saying those things, as others have said. Um, and I've also had patients where we've talked about quite extensive trauma history and have talked about that with patients about what would you feel comfortable including in your note. And here's why I put it in the note, because it helps other care providers. But I want to make sure that we're on the same page about this. Yeah, there's also comments about this include just the bare minimum if they're a victim of sexual assault. Um, really try to ask about disclosures and if they want it documented. Yeah, I think this point about unsafe partners, I've had patients also say that their partner has access to their MyChart, and I think that's also important in that as well. Other comments and other thoughts? Wonderful. Thank you so much for this really helpful and thoughtful conversation about trauma-informed care. Yeah,
Yeah, thank you all so much for engaging with me.
okay. We will take a 5-minute break, come back right at 10:45 on the dot so we can finish at 11:30 exactly. Lots of appreciation coming through.